Good day. I am here to discuss today about two important topics which are very timely. This is atopic dermatitis, the Unending March, and your complete next generation emollient regimen, which is Ceradan. I'm your speaker for tonight, Gisela Trano Sarmiento, and thank you to Hyphens Pharma for this invitation. The content of my lecture will be atopic dermatitis, epidemiology and the disease burden of AD, skin barrier, current recommended management strategies, and ceramide-dominant lipid-based emollients. So what is atopic dermatitis? A lot of facts about it is that it's a very, very common condition. It is long-lasting. That's the reason it's called a chronic itchiness or chronic condition. It commonly starts in children, but some of the patients that we see right now may also have presented their atopic dermatitis at a late stage, at 38 years old, at 43 years old, or what we say fourth or fifth decade of life. Risk factors are personal or family histories of allergies or asthma, part of a range of other allergic conditions known as atopic march. And because of its allergic origin, there is an increase in the immunoglobulin E, or what we call the IgE. So this is actually your atopic march. Your AD is considered the very first manifestation of an allergic predisposition. And as seen in this graph, the incidence, that is, the number of new cases occurring in any given population, is highest before the age of 5 years, followed by food allergies and asthma, and finally allergic rhinitis. Now, this is an important theory as it denotes that atopic dermatitis marks the initial signs in most individuals that they have some form of abnormality at the epithelial barrier. First the skin, then progressing on to the airways, which is asthma and allergic rhinitis. Now, 50% of all with AD developed other allergic symptoms within the first year of life. So that's the common thing about it. Now, this is actually the scratch-itch cycle, wherein your pruritus or itching is the most dominant symptoms of AD. The itching leads to a scratch-itch or the itch-scratch cycle that increases the impairment of the epidermal barrier. Now, this enhances the inflammatory reaction, which in turn perpetuates the disease. The itch can be attributed to the dryness of the skin, as the severity of the itchiness has been associated with the transepidermal water loss. This explains why that the TEW may be increased in the night and the nighttime itch increases. Now, there is an increase on the loss of the moisture, which is your natural moisturizing factor. When the itch is controlled, it can prevent the exacerbation of AD. Now, the scratch or the itch scratch cycle is very, very pathognomonic. Let's take another look at the cycle itself. The pruritus or the itching is the most dominant symptoms of your AD. This leads to the cycle that impairs the epidermal barrier and enhances the inflammatory reaction, in turn perpetuates the disease. So you'll see here itching, scratching, and then the skin barrier deterioration. So the first sign is actually a very, very dry skin that leads to itchiness, and the patient would scratch it repetitively, and then you desquamate or you decrease the skin barrier. The crucial role of the ceramide in the skin health is that your ceramides are essential for life in dry land. Any major disturbances in its production or transport can be lethal, as it prevents water loss from the skin. And in fact, in AD, the reduction of ceramides causes the compromise of the skin structure. So what are the three lipids that we know of that are so important? These are the ceramides, the cholesterol, and your fatty acid. Now, your ceramides are the most dominant lipids in the stratum corneum, and this is actually 1/3 of the lipid molecules, or 50% of the lipid by weight. The ceramides, as the biological actions are needed for the activation of enzymes, it forms the lamellar structures that is made of lipids, and it coats the envelopes of the skin cells. It forms a part of the brick and mortar structure. The lipid lamellar structure forming the mortar, and the structures fill the interspaces between the skin cells and the brick, which are the bricks. And additionally, the structure of the ceramides allow for the tight packing of the skin. So this is actually ceramide deficiency in AD, or skin elevated of skin pH. So if you notice here, one of the crucial factors for AD is the marked decrease in ceramides, and you see it here, less than 30%. In AD, there's approximately 50% reduction of total total lipids and more than 30% reduction of the ceramides. So what happens? It's now the dry skin that will perpetuate into itchiness. So the epidemiology and disease burden of AD is very, very important. You'll see here that the incidence of the AD worldwide varies greatly from country to country. And in fact, the adults are affected more than the adults are really, really affected. Generally, if you'll notice, about 20 or 15 to 20% of children and 13% of adults are affected. And that's about 85% of those who develop AD would do so before their 5th birthday. And the development is actually, however, 70% of these children would outgrow the AD by the time they reach adolescence. The incidence of the AD has increased 2 to 3-fold from the past decades, and mainly due to the industrialization and people moving on the urban environment. So the reduction per se, actually, that the reduction of exposure to a variety of microorganisms resulting in reduced immune tolerance. You'll see here also that in Western countries, where the prevalence and the number of existing and new cases has reached the high peak of about 20%, and the incidence has plateaued. But however, in lower income countries and certain regions like Southeast Asia, the numbers are still increasing. This is true mainly in young children around age of 6 to 7 years old, as depicted by this particular figure. The burden of the disease is really, really at hand. Your AD have a significant negative effect on the HRQL of the children per se. So in their family in many cases. So most cases, impact stems from the consistent scratching in its active stage as well as its physical manifestation. It also affects the children largely, but indirectly affects the children's carers and parents. Through the duration of sleep may not be significantly different between children with and without AD, the quality of sleep is really affected. In a study sample of almost 14,000 children followed up over 11 years, the researchers found that children with active AD experienced the worst sleep quality throughout their childhood. Though the effect was more profound in children who have or have had severe AD, it was still significant in those with inactive and mild disease. And another component of disturbed sleep was the time spent awake after sleep onset, which was consistently more in children with AD. And this is actually ranging from 45 to 100 minutes, and that is really long. There was also an association with increased nighttime awakenings, difficulty of falling asleep, and nightmares, and early morning awakenings. So one of the reasons that may explain why children in the remission or children in remission or history of AD may suffer from poor sleep quality is that it's not in the scratching alone, but the damaged skin, making these children more sensitive to sensory stimulation at night. So other factors that could negatively impair the health-related quality of life or the HRQOL in children with AD are the psychosocial factors or the impact of the act of scratching and the sensitivity to the damaged skin. So additionally, parents are also affected by children with AD. So the burden that AD may have significantly negative effect on the HRQOL of children and their family in many cases is that the carers and parents are also really affected. Why? Caring for their children, especially those who are younger and with more severe AD, can cause exhaustion, feelings of hopelessness, and guilt. And anger is also associated as they see their children suffer. So the cost of the medications increases, and they need to take time off from work to care for their children may also lead to financial burden. So in a study done in Singapore to determine the factors influencing quality of life in children with AD and their caregivers, the researchers found that the health-related quality of life in children caregivers were negatively impacted as well. So, this graph shows association between the average HRQOL scores of the children and the caregivers' physical and mental health scores. So the higher the value on the x-axis, the worse the HRQL scores for the children. The line for both the physical And the mental health scores shows a decline, actually, although not steep, but it's still very, very significant. So your skin barrier, all right? AD is a chronic condition, and mainly, of course, it affects a lot of the younger children. And of course, the study done across the countries in the Asia Pacific determined when the economic burden of childhood AD varies widely between countries. Direct and indirect costs that were reported included hospitalization, lab tests, and so forth. So there's so many things to consider when you're doing a lot of atopic dermatitis studies. Now, the skin barrier is so important because you will see here, this is where everything is actually seen. So one of the major function of the skin is to act as a barrier. So this is protecting the body, if you notice. So this is for your epidermis, your dermis, and your subcutaneous tissue. And if you notice, actually, the four barrier functions is permeability, antimicrobial immune response, photoprotection, and of course the antioxidants. Now the three ways for the barrier to really function and work is that there should be a very good balance and interplay of the physical, chemical, and immunological functions. So the stratum corneum per se is actually a very important area for us to determine the illness of your AD. That's your epidermis, your stratum corneum, your lucidum, granulosum, spinosum, and basale. Then you also have your dermis. So the stratum corneum provides the physical barrier, and as it does not allow any harmful agents entering from the outside and prevents important materials such as excessive moisture from escaping into the air. So you need the thickness and pigmentation and the protein barrier of the stratum corneum, because a lot of the UV would enter, and the chemical barrier that is known as the acid mantle is also presented. This is contributing the acidic nature of the skin and protects the body in two ways. So first is by providing a suitable environment for the good bacteria naturally found in the skin to grow and thrive. And the same acidic environment, however, is detrimental to harmful bacteria that attempt to live on the skin. So they thrive mainly in an alkaline environment. The second form of protection is that acidic composition of the skin is in an optimal environment for the functioning of important enzymes needed to maintain the lipid component of the stratum corneum. So chemically, the presence of these antioxidants within the surface of the skin scavenges the free radicals. So this creates the oxidative stress like your UV radiation to protect the skin. So there are so many range of immune cells within the skin. For example, you have the Langerhans cells, some dendritic cells, which are the macrophages, and they defend the body against invading microorganisms via various different mechanism. So you have this barrier, your maintenance of four different barriers. So to maintain the stratum corneum, you have to maintain the water content or the balance of the permeability barrier, prevention and responses to invasion of microorganisms that are harmful to us. Of course, the antimicrobial barrier, the immune response barrier, and reduction of the effects of UV light exposure, that's your photoprotection barrier, and reducing the effects of oxidative stress, which is the antioxidant barrier. This is actually the compromised skin, and a lot of factors are going on this interplay. The compromised skin is very, very important on a discussion of the AD. So this actually result from external or internal factors that increase the transepidermal water loss, so that's your TEWL, and alter the protein and lipid components of your stratum corneum. So in normal circumstances, actually, the natural self-repair mechanism of stratum corneum are able to cope with the insults. But overexposure to these factors, which builds what we call the filaggrin breakdown products, and you know that your filaggrin are the gates of your body. Now, this is overexposure without taking care of the skin, causing the stratum corneum to overstress. Now, this will lead to an increase in the transepidermal water loss from the inside that results in incomplete desquamation, loss of skin elasticity, increased skin rigidity, and epidermal proliferation. So your external factors that can cause compromised skin are your improper skincare, exposure to irritants, topical agents, low humidity, or the dry weather. Some underlying conditions also can also contribute and exacerbate the development and progression of your compromised skin. And actually, this includes your conditions of atopic dermatitis, psoriasis, diabetes, increasing age, and the list goes on. Now, this causes the stratum corneum to become disrupted, leading to increased moisture loss. That's the reason you get to have dry skin, and the alteration of your matrix of your stratum corneum. So this results further in incomplete desquamation, loss of elasticity, increased rigidity, and epidermal desquamation. So you will notice here that the compromised skin barrier in atopic dermatitis is that it's a condition that causes inflammation of the skin due to allergic reaction, which we will cover in this data later. So this actually can occur in any individuals who are unable to produce adequate amounts of certain ceramides, in addition to other altered normal biology, causing their normal or baseline transepidermal water loss to increase, versus someone who does not even have atopic dermatitis. So during this allergic reaction of the skin, like an eczema, this transepidermal water loss then further increases. So that is really the problem behind this increase. This will now eventually actually increases individuals' risk of developing compromised skin barrier over time. So there's a deep dive between your healthy skin barrier and your defective skin, actually. So if you notice here, that's a healthy skin barrier from your epidermis to your dermis to your subcutaneous layer. And your epidermis would always have the filaggrin, which is the gates of your skin. And once the gates are closed, nothing can even go out, or just a small particle of that. It's actually holding the very good moisture underneath, which is the dermis, containing your natural moisturizing factor. So that is the healthy barrier skin. Now, if you have all of these irritants, that will preclude the individual who has atopic dermatitis to end up with a lot of FBF, or what we call the filaggrin breakdown product, FBP rather. So what will happen is that it's going to be broken on the surface, and a lot of the moisture coming from the dermis is actually coming out. So, and that per se will give you now the signs of this defect, that is actually defective skin barrier. Your filaggrin breakdown products, which are affected by the allergens and by the irritants, and increasing now your high loss of your natural moisturizing factor, or what we call the high transepidermal water loss. So that is now the defective barrier. So the compromised skin barrier becomes presenting with, first and foremost, skin dryness, which is repetitive. It becomes so itchy because the area is so dry, and the patient would keep on scratching it, and will because of the incomplete desquamation, the loss of elasticity, the increased rigidity of the skin layer, the epidermal proliferation, that will now lead to scaling, and then flaking. You also have fissures and hyperkeratosis. And then furthermore, there's dry skin sit on top of another dry skin, and you get to have really the increased skin markings, or hyperkeratosis, or what we call scleroderma also. So these are the things that we are really trying to avoid and really see as a presentation of almost all of our atopic dermatitis skin patients. So compromised skin, when the stratum corneum permeability barrier is disrupted and there is no adequate treatment initiated, or the avoidance of triggers are done, the pathology will become apparent as clinical signs, and it will go on and go on, and it will have some microbes that will sit on the area and will proliferate further, and then ending up the skin lesion into an eczema. So the abnormal desquamation will cause clumping of the corneocyte, that is visually appearing as scaling and flaking of the skin, the loss of elasticity, rigidity, micro and macro, epidermal proliferation. So the best visual actually that you can tell your patient is hardened and cracked heels, and that most people know about. So current management strategies are so important. The goal is to actually include the control of symptoms, reduction of flares, and improvement in quality of life. That is actually the Asia Pacific guidelines that has been added to this. We need to really reduce the flares. We have to improve the quality of life. We maintain the remission by preventing and reducing the relapse. So preventing the complications such as infection, because infection may set in bacterial, viral, and of course the opportunistic infections, which are the fungal. Reducing the extent and severity of AD, clearance of lesions, and return of the normal barrier. And of course, we want to maintain remission, preventing and reducing the relapse. So this is actually achieved if there's trigger avoidance, maintaining an optimal barrier, we do reduce the inflammation, and of course, a very, very good patient education. So the goals of management include control of symptoms, reduction of flares, and improvement of life. So trigger avoidance, individuals based on careful history and the result of specific allergy testing. There's so many allergy testing that you can do. There's Fabry allergy testing, there's patch allergy testing, and the list goes on. Then you maintain an optimal skin barrier function with use of emollients, moisturizers and emollients, and careful hydration such as soaking in a warm bath for at least 10 minutes followed with immediate moisturizer application. The reduction of skin inflammation with anti-inflammatory therapy is really a must. This is usually achieved by topical corticosteroid. So you have the spectrum right now. The potency should be individualized based on the severity of the dermatitis and the location of the affected area, the surface of the affected area, and most importantly, the age of the patient. If you have pediatric age group, especially 1-year-old and so forth, you have to really start on the most bottom, the class or the rank 6. That is your hydrocortisone, your desonide, and so forth, right? Then as you go along the spectrum, depending on the age, depending on the presentation, then you may give your rank or class 4, class 3, class 2, or 1, then you get to have to do your triamcinolone, your clobetasol, or betamethasone. Usually in flare-ups, the dose is increased temporarily or a more potent steroid or agent is used for a short period of time, as I've said. So there's another group of agents called calcineurin inhibitors that are also anti-inflammatory, which is used as second line anti-inflammatory in patients or more than 2 years of age. They have recently becoming an integral part of the management of AD. Your patient education should include information on the condition and avoidance of triggers, as well as properly following the management plan. It should also be including discussing the patient's or caregiver's parents on how this management treatments would help and what the long and short-term goals of therapy is. So this is actually the recommended management algorithm for your AD. So just to bring it up on a more better aspect, based on this diagram, note that the first step forms the foundation, all right, of the management throughout, and it includes particularly skincare. Skincare here refers to washing and moisturizing with emollients. Other strategies are educational intervention and identification and management of the aggravating factors. So as the condition becomes more severe, other prescription medicines are added or comes into play. In mild AD, topical steroids or calcineurin inhibitors are used, but in moderate AD, wet wrapped therapy, phototherapy is added, and finally in severe AD, systematic treatment is started. As the condition improves, then the treatment is stepped down, but the products focused on the skincare, we will learn more about this. All right, so this is actually a recommended management algorithm. So what about washing or bathing in AD? Most soaps are alkaline in nature. It has shown that to increase the pH of the skin by units 3 lasting for 90 minutes, it is recommended that either non-soap, mild, non-fat stripping, or emollient bath oils or soap substitute cleansers should be used in AD. So universally, it is recommended that emollients or moisturizers are used immediately after bath. Really true, actually, the oils are really coming into play already. Now, moisturizers, which are mainstays of the general management of atopic dermatitis and recommended as first-line therapy, is also actually a must. Emollients are the most highly recommended moisturizer among the guidelines. And the Singapore guidelines recommends emollients with ceramide for skin barrier repair. That has been in the industry for more than 20 years actually. So this may contain exclusive increased moisture content as an emollient and can also contain humectants to increase moisture retaining capacity. So providing a steroid-sparing alternative, it can be added when bathing or showering is done. Should be applied 2 to 3 times a day, and the recommended um, treatment, regardless of severity of atopic dermatitis, actually are your emollients. So, emollients are topically applied agents designed to soften the skin and really make it smooth, and it's often created with addition of humectants or occlusive. So, humectants are substances that have a moisture retaining capacity and occlusive agents, and then of course provides a layer of lipid to slow the water loss. So, we really put a very good emphasis on barrier corrective function that normalizes the barrier, because it will reduce the inflammation by reducing the chemicals involved in inflammation. And when you talk of the pH, therefore you reduce also the serine protease activity. You prevent the allergens ingress, preventing the filaggrin breakdown product to really go to the filaggrin or the gates of the stratum corneum, and also possess anti-inflammatory and antimicrobial properties, and that's the emollient. When used together with topical corticosteroid, it has shown to significantly improve dry skin, or what we call cirrhosis, and provide reduced itchiness compared to corticosteroid treatment alone. So it's also important for the maintenance of improvement of after corticosteroid treatment is stopped. So this is actually the feature of an ideal emollient and its effect on the atopic dermatitis. Although anti-inflammatory treatment reduces the disease severity by suppressing the immune reaction that occurs in AD, they do not fully correct the primary underlying barrier abnormalities, because once you have AD, actually you really have it for life. You just really need to know what's your battle behind. The ideal emollients for barrier repair therapy, of course, should normalize the epidermal barrier function by reducing the transepidermal water loss. So we improve the stratum corneum hydration and protecting the skin from allergen penetration. So your AD treatment must restore the barrier and its function, as well as suppress your inflammation and control the itchiness. Now, this table shows us some of the ideal emollients features and effects on its atopic dermatitis. As seen earlier, the occlusion property helps with artificial repair of the barrier. So you can see here that the humectant improves hydration and replenishes actually the lost natural moisturizing factor. The other features, inclusions of the skin lipids, would repair the skin barrier and correct the lipid abnormality. And then as you contain mild surfactants to reduce triggering, the AD does not have negative effects on skin barrier, and it has a closed capacity, a closed skin pH, and high buffering capacity to normalize your skin pH. So the normal skin pH is 4 to 5, and restoration of acidic mantle, which is very important. Be able to increase the AMP so that you'll decrease the risk of infection. So when we look at the picture of an ideal emollient, we see that having an emollient that is ceramide dominant is the most important in successfully normalizing the skin pH. That is really playing the most important feature. Okay, so going further, your ceramide-dominant lipid-based emollients are very pathognomonic. So look at this slide. Actually, the properties of physiologic lipid-based products differ from non-physiologic agents, because when compared with other emollients that are exclusive or occlusive rather, or the other humectants in nature, ceramide-dominant physiologic lipid-based products are thought to participate in the physiologic lipid replacement in AD. So why? Because it penetrates the stratum corneum, which is really good. It becomes incorporated into the keratinocytes, and therefore it processes in the lamellar bodies and then secreted back into the stratum corneum. That's number 3 there. And then it fundamentally actually replaces the missing ceramides by becoming incorporated into the process of the ceramide secretion. So studies have also shown that if you have adequate lipid replacement therapy, inflammation is reduced, and actually the epidermal barrier is restored. And comparable to that of topical corticosteroid cream, your ceramide-dominant lipid-based emollient is really good in giving a more luster or better skin texture for that matter. So, but we are really needing to think, and we should really think if all ceramide-dominant lipid-based products are created equal. So, with that, actually, this is actually optimal lipid ratio for skin repair. So if you look actually at this particular slide, there is a study demonstrated that with the optimal lipid ratio of ceramide, this is actually 3:1:1. So ceramide, cholesterol, and your fatty acid. That's the 3:1:1 optimal lipid ratio for skin repair. This had the lowest transepidermal water loss. Look at that. Observed amongst all leading products, and as faster accelerated skin barrier recovery was appreciated compared to other lipid formulations. This is because the unique ration of the lipids mimics the psychological ratio in the skin and also the physiological ratio in the skin, and actually this is actually the Ceradan. The makeup of the Ceradan is very much into 3:1:1 ratio with the highest level of the ceramides compared to the others actually. So, the ceramide-dominant lipid-based emollient efficacy is actually twice daily applications. For some of my patients, I made them put 3 times if it's really very itchy. This actually showed significant improvement of severity in AD by the 3rd week of application. And twice daily application showed significant reduction of the transepidermal water loss by the 3rd week as well. And actually gradual hydration of the stratum corneum until significant at week 20, and integrity of the stratum corneum improved progressively. And there was improvement of the barrier function, reduction in severity of the pruritus, and thus reducing the scratch itch scratch cycle as well. Alright, so significantly improved the quality of life or the quality of living of these individuals in any age spectrum for that matter. So, actually, this is Ceradan AD range establishing a comprehensive complementary topical management in AD. So, products are considered ceramide-dominant and therefore contain actually the properties of ceramide-dominant products as discussed earlier, which is not only to replenish the ceramide but to correct the permeability of the barrier function of the stratum corneum. So all the products range is made of the ratio similar to that found physiologically, that is ceramides being the most abundant, and followed by equal parts of the cholesterol and free fatty acid. This ratio has actually been shown to exert optimal ceramide-dominant emollient activities. Now, a clinical study done also using Ceradan, as was discussed earlier, showed that Ceradan clearly improves the AD in individuals as assessed by the patients themselves and their doctors. In another study done in Singapore, amongst Singaporean children, the Ceradan prevented 1 out of 2 AD relapse, and this is actually a very good news. And while in the same study as 0.4 and 9 and 10 users were satisfied with the regimen, and majority that said that they would use it again. Alright, so this is 3:1:1 optimal lipid ratio for skin repair. So the study demonstrated that with the optimal lipid ratio of 3:1:1, the lowest TEW was observed. So this accelerates the optimal skin barrier repair. So with that, actually, there's a complete range and category of the Ceradan. This is actually the complete next generation emollient regimen that rebuilds the skin's protective barrier. So there's intensive therapy, repair cream, and smoothing actually. There's also moisturization. This is actually for the intensive therapy, is a part of the emollient regimen used in combination with anti-inflammatory therapy, controlling the itch scratch cycle. And then of course for the moisturizer, there's also step-down application after flare-ups has subsided, and you have to use it daily to keep the skin moist and hydrated. There's also a moisturizing wash that will make the pH on the acidic mantle. And then of course you have the child essential, which is the Ceramos, which is actually the mosquito repellent cream for the kids. Okay, and that how the products are used. So for the treatment of the flares, for maintenance during remission, and we can continue using it for the many months and weeks to really be able to complement that the children will not do the scratch scratch cycle once again, even the adults. So use a gentle soap-free wash daily as part of the AD management. So that is a step one. You really need to cleanse, and then put your if there's a need for a steroid, then put the corticosteroid, and put the emollients. Okay, so how are this done? This treatment step 2 is controlling the scratch itch cycle with the soothing gel. Step 3 is repairing the defective skin barrier using the Ceradan cream. And of course, during maintenance or during revision, you have to apply the moisturizer at least twice daily. All right, and for the children, you may use also the mosquito repellent. So with that, actually, I thank you for joining us in this lecture. And of course, even if there's pandemic, and of course there's also a global increase in the atopic dermatitis, which is now actually about 45% worldwide, and each country is afflicted with atopic dermatitis. Together, we will get through this. Actually, with that, thank you very much for listening.